Welcome to today's episode of AudioBoards. This is the very first episode of our Intern Series, your crash course through the conditions you'll see most often in the hospital. In this series, we break down high-yield topics in a way that actually sticks, fast, practical, and clinically useful. And what better way to start than with one of the most common and most dangerous hospital presentations, alcohol withdrawal syndrome. From the timeline of symptoms to what's happening in the brain to how we treat it on the floors and in the ICU, we're breaking it all down today. Let's dive in. Alcohol withdrawal syndrome is a common clinical condition that occurs when a chronic heavy drinker suddenly stops or significantly reduces their alcohol intake. And one of the most important things to understand about alcohol withdrawal is that the severity and type of symptoms depend almost entirely on how much time has passed since the last drink. Let's walk through that timeline. In the first 6 to 36 hours, patients may develop tremulousness, anxiety, sweating or diaphoresis, gastrointestinal upset, and even tongue fasciculations. As we move into the 12 to 48-hour window, things can escalate. This is when patients are at risk for withdrawal seizures and alcoholic hallucinosis, meaning visual or tactile hallucinations, while the patient remains oriented. And then from 48 to 96 hours comes the most dangerous phase. This is when patients are at the highest risk for delirium tremens, or DTs, a true medical emergency marked by profound confusion, autonomic instability with high heart rate and high blood pressure, and hyperthermia. Even with treatment, the mortality rate can reach up to 5%. So why does the body react this way? Let's make it simple. Think of your brain like a car with two pedals. One pedal is the brake. That's a neurotransmitter called GABA. The other pedal is the gas. That's glutamate. GABA calms the brain. Glutamate excites the brain. Your nervous system is constantly trying to keep those two perfectly balanced. Now enter alcohol. Alcohol acts like extra GABA. It slams on the brake. That's why people feel relaxed, slow, calm, and sleepy when they drink. But the brain doesn't like being thrown off balance. So with chronic drinking, it adapts. Over time, it weakens the brake by removing GABA receptors, and it strengthens the gas pedal by adding more glutamate receptors. This is what we call tolerance. The brain is quietly preparing to fight alcohol's effects. Now imagine what happens when alcohol suddenly disappears. The brake is broken, and the gas pedal is floored. There's no alcohol providing calming signals. There's reduced GABA activity, and there's excessive glutamate activity. The nervous system goes into overdrive, and that overdrive is what causes tremors, anxiety, sweating, high heart rate and blood pressure, hallucinations, seizures, and in severe cases, delirium tremens. The brain is essentially in an electrical storm. So how do clinicians measure and treat this storm? We use the CIWA scale, the Clinical Institute Withdrawal Assessment. You can even find it on MD Calculator. A CIWA-guided protocol is a symptom-triggered treatment plan, meaning medication is only given when symptoms reach certain severity levels. Instead of fixed dosing schedules, patients are monitored regularly, and treatment is adjusted in real time based on physical and mental status. The CIWA scale evaluates physical symptoms, psychological symptoms, and sensory symptoms. Now here's how CIWA scores guide treatment. Very mild withdrawal corresponds to a CIWA score less than 10. These patients are often treated outpatient using benzodiazepine-sparing strategies such as gabapentin. Mild withdrawal corresponds to CIWA scores between 10 and 15. These patients may be treated in the outpatient setting or emergency department with long-acting benzodiazepines like diazepam or chlordiazepoxide. Moderate to severe withdrawal corresponds to CIWA scores greater than 15 to 20 and usually requires inpatient care with symptom-triggered benzodiazepines through protocol. And scores greater than 20 indicate severe withdrawal, with high risk for complications, requiring intensive inpatient monitoring and aggressive medication. Benzodiazepines are preferred because of their self-tapering effect, but in patients with liver disease, safer options are the lot drugs, lorazepam, oxazepam, and temazepam. In severe cases where benzodiazepines aren't enough, phenobarbital may be used, although it carries a risk of respiratory depression and may require ICU monitoring. Hospitalized patients also routinely receive thiamine to prevent Wernicke's encephalopathy, along with fluid and nutritional support to manage the physical stress of withdrawal. When monitoring is available, symptom-triggered dosing is preferred. For severe withdrawal, especially with Kiwa greater than or equal to 19, early front-loading with moderate to high benzodiazepine doses is recommended. Fixed dose schedules can be used when symptom-triggered protocols aren't practical, but they still require close monitoring and PRN medication. Now let's talk about long-term recovery. The goal of hospitalization isn't just to survive withdrawal, it's to prevent relapse. Psychosocial support includes substance use navigators, intensive outpatient programs, and Alcoholics Anonymous. Medication-assisted treatment options include naltrexone, an opioid antagonist that reduces cravings and is usually first line; acamprosate, a second-line option taken 3 times daily; disulfiram, which causes an uncomfortable flushing reaction if alcohol is consumed and is rarely used since it doesn't reduce cravings; and topiramate, often reserved for patients who also have seizure disorders. Now here's the common dosing used in treating alcohol withdrawal, expressed in chlordiazepoxide equivalents. For mild withdrawal with TIWA less than 10, 25 to 50 mg by mouth. For moderate withdrawal with TIWA between 10 and 18, 50 to 100 mg by mouth. For severe withdrawal with TIWA greater than or equal to 19, 75 to 100 mg by mouth. With symptom-triggered regimens, dosing is 25 to 100 mg by mouth every 4 to 6 hours, when TIWA is 10 or higher, with additional PRN doses based on symptoms. For fixed-dose tapering, Day 1, 25 to 100 mg every 4 to 6 hours, Day 2, every 6 to 8 hours, Day 3, every 8 to 12 hours, Day 4, bedtime dosing, optional Day 5, bedtime dosing. For front-loading in severe withdrawal, 50 to 100 mg by mouth every 1 to 2 hours until TIWA is less than 10, or every 1 to 2 hours for 3 doses. And for phenobarbital, typical dosing includes 10 mg per kilogram intravenously over about 30 minutes, or 60 to 260 mg by mouth or intramuscularly. And that wraps up the very first episode of the AudioBoards Intern Series. More crash course episodes are coming, covering the conditions you'll face every day in the hospital, explained clearly, quickly, and in a way that sticks. Thanks for listening to AudioBoards. Stay tuned for more educational content in our next episode. The views and opinions expressed on the AudioBoards podcast do not necessarily reflect those of our employers. This podcast is for educational purposes only and should not be used to diagnose or treat any medical conditions. It is not a substitute for professional medical advice. Always consult a qualified board-certified healthcare provider for any medical concern.